Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
I explained to the patient at the first visit that this is a long path that we have to walk down. And there'll be many turns and dead ends, and then we're going to have to back up and go down the path, a different way. The ultimate concept is these crystal clear days, getting to those days. And that's the aspirational goal that we set for ourselves.
Welcome to Talking Head Pain, the podcast that confronts head pain head on. I'm your host, Joe Koh, Director of Therapeutic Area Growth and Integration at the Global Healthy Living Foundation, as well as co-president of GHLF Canada. I've been a migraine patient for over 20 years, so I know firsthand how debilitating this disease can be. I'm here today with a very special guest, Dr. Andrew Blumenfeld. He is a director of the Los Angeles Headache Center, and you may know him because he's a world-renowned headache specialist who helped develop the Botox injection protocol that was used in the pivotal migraine trials. How are you doing today, doctor?
Very well. Thanks for inviting me to do this.
My pleasure. Can you share a little bit about your background and what brought you to the great field of headache medicine?
Well, in my family, there's a very strong history of migraine. Both my daughters have it. My mother had it. So there's a strong genetic background on the female side. And when I was younger, I had some migraine, nothing like a chronic migraine pattern, but one of my daughters does have a chronic migraine pattern. So that led me, as I was training in neurology, to focus a lot on migraine and then just continue doing that once I went into practice. And now, essentially, I've evolved to a practice that only does headache medicine.
That's really amazing. And we're thankful as a headache and migraine community that we have folks like you that have dedicated their career to understand this often misunderstood disease. There's a term that a lot of us hear and that's used more frequently now as newer medications have come to market. The term is migraine freedom. What is migraine freedom and how does that look for the patients that you see?
This term, in part, developed from one of my patients, and we started to present at symposia and advisory meetings this concept of migraine freedom. And so it's useful to hear about this patient's journey. And she was an artist, a graphic artist, and she did a self-portrait of herself. When she was coming to a visit, she would give me this drawing of herself. And basically, it showed her face with a construction ball heading towards her head and hitting her skull, and devastatingly painful. And you could get the concept of a one-sided painful headache as that construction ball repeatedly hit her head. But then the more interesting aspect was that in front of her face, she painted prison bars. And when I asked her what she meant by the prison bars, she explained that the disease had imprisoned her because she didn't know when the construction ball was going to hit. And this was back in 2012. And we tried many different treatments to get her headaches under control. And we weren't successful. Nothing was working well for her. And as a provider trying to help the patient, I was also imprisoned. My hands were tied by what was available to me. And it was pretty frustrating for both of us to try and get grips on this disease that was so disabling to her and was producing so much anxiety between attacks that the burden was terrific. And so that pattern has shifted. Since 2018, we've had a lot of new medicines become available to us that have allowed us to a large extent to start breaking down these prison bars. And that led to the concept of migraine freedom. Now, the term is not universally accepted by headache experts. There's a lot of controversy around it because the disease of migraine is not curable. We control the disease with the medications that we use. And so it's not that you're completely free of it, but what the concept is to get better control of the situation. And that control has to be defined individually. Each person would define control, what it means to them. Maybe it means they don't go to the emergency room because they have a better plan. Maybe it means they can work more days out of the month because they're not having as many headaches. So it doesn't necessarily mean that you're free of headache. Ultimately, that is the ideal. That is the concept that we would like to get to. And what it does with providers, creating this concept of migraine freedom, is that it encourages you to keep thinking about additional ways to get the patient a little bit better. The old method of treating migraine was what I would call a monotherapeutic approach. You would try one treatment, and if it didn't work, you'd switch from that treatment to the next. But this concept is, let's say that first treatment gave you 25% improvement. Well, let's keep the 25% and layer on the next treatment, maybe get another 25%, and then layer on the third treatment. So this requires that treatments be very well tolerated and that you can do this layering over a series of visits. This is not a quick fix.
There are a couple of things that you said that I want to reflect on and just state back because it's important for people to really hear. I think it's really powerful that you said that you were also imprisoned with your patient. And that statement shows a care and investment in treatment, which if all providers had the time, energy, and care to do that, I think that it would be a quite different space for folks. So that's really important to hear that there are providers who are partners in your care who engage in shared decision making. So I wanted our audience to really hear that and underline that point. I also thought it was important to underscore how the concept of migraine freedom, in your opinion and assessment, encourages providers to keep thinking and not settle. And I know as a patient and as a patient advocacy organization, we do a lot of work talking to patients about, or people living with migraine, however you want to define yourself, about how not to settle, how to push. So it's really important that we're hearing that too from the provider standpoint, that there are providers saying to other providers, don't let your patients settle. 25% reduction in symptoms and headache frequency is great. Can we get it to 35% or 50% or 70%? And that concept ties into the next question that I want to ask you. What is this multimodal layering approach to migraine treatment? Because we know that migraine is so complex and individualized. And are people using topics and ideas like personalized and precision medicine when looking at patients and what treatments they might use?
Yeah, so we've just actually published a paper on this, the multimodal approach to migraine freedom. And it's the start of an initiative to educate the broader headache community about these concepts. And the two main thrusts to this. The first is to make sure that there are no drivers of the headache disorder that have gone unaddressed. So things like, let's just say, sleep apnea, not diagnosing sleep apnea, because sleep apnea can cause headache and would obviously exacerbate the underlying migraine. You now have two ways of getting headache, and if you're only treating one of them, you wouldn't be successful. So multimodal encompasses making sure that you've addressed all the conditions that could be driving the headache, and you've brought treatments to bear on each of those conditions. Then when you get to the migraine side of it, it's finding treatments that can work synergistically together. So it's looking at mechanism of action of the different medications and then layering them on so that they're complementary. Because migraine is a complicated disease where during the attack, there are multiple nerve pathways that are being activated and multiple different chemicals that are being released in the brain. And we want to find a method of getting as many of those pathways blocked. But then on the other hand, we also have to do it in a way that the treatments don't cause a lot of adverse events that may be worse than the disease. So it's a lot of work on this. And getting back to the points that you made about the provider working with the patient, I explained to the patient at the first visit that this is a long path that we have to walk down. And there'll be many turns and dead ends, and then you're going to have to back up and go down the path, a different way. The ultimate concept is these crystal clear days, getting to those days. And that's the aspirational goal that we set for ourselves. But it's a multiple visit, long journey that the two of you are going to take together. And that's an important concept because there will be failed attempts. Not everything you try is going to work. And you've got to just keep rethinking together. It's what we call a shared decision-making process. The provider is educating the patient about the options, And then you are talking them through and deciding which is the best option to focus on to get to that ultimate goal. But there's a lot of patience and a lot of partnering in getting to that. In terms of precision medicine, we don't have biomarkers that help us identify which treatments will work best for any individual. Hopefully, in the future, that will evolve. The chemicals that are being secreted in the brain, those have all started to be identified. And it's just a matter of finding tests that can measure them outside of a research study. And then the medicines could be much more targeted. So you'd have much more option of not failing with a particular treatment. But clinically, we can sometimes get clues by taking a very careful history. For example, let's look at a patient who, when they're younger, had menstrually related migraine and then got pregnant and the headaches went away. They didn't have any headaches during pregnancy, but then postpartum, when they stopped breastfeeding, the headaches came back with a real flurry of activity. And now they perimenopausal with a lot of headaches occurring. This is quite a common pattern. But what all of that tells me is that that type of headache is driven by drops in estrogen. So when you're menstruating, your estrogen level is at a low point. When you're pregnant, your estrogen is at a high point. When you're postpartum, it's low. When you're perimenopausal, it's low. So estrogen is playing a huge role in that patient's course. And so do we supplement estrogen? But that has its own issues, right? Breast cancer risks, blood clot risks. But that potentially is the driver. As estrogen levels drop, your nerve endings in your brain can release more CGRP. And so using a drug that blocks CGRP, would that work well in that scenario? So there are a lot of clues that we get. And a lot of it is like being a detective to try and work out what is going to be the best route for each person.
There were a couple of things I wanted to touch on from what you shared. A concept of managing the expectations of treatment is really important for folks to understand. And you framed that very nicely about the long journey, and there might be roadblocks and you might have to take some steps back to move forward. But how does that work in practice, managing expectations with your patients?
I think it's very important to set these expectations right up front at the very first visit. Once you make the diagnosis, that you start to discuss these different treatment options. And what patients don't always understand is the insurance company tend to have a lot of barriers. And physicians might have to pick medications that are not really their first choice. Medicines that might have a lot more adverse events because the insurance companies require that you fail on these treatments. An adverse event counts as failure before they'll allow you to get to the more targeted treatments. So that whole discussion needs to take place. Otherwise, there will be miscommunication because you're going to get a medicine that maybe gives you an adverse event that you really don't like. But this is the world we find ourselves living in order to work through the system. And then this shared decision-making process, which requires a very balanced discussion about all the treatments. In other words, let's say you were discussing getting a Botox injection or a monoclonal antibody targeting CGRP. It wouldn't be fair to say, do you want 31 injections with Botox versus one injection with a monoclonal? Because by saying it like that, you're basically making the decision. Nobody is going to pick 31 over one injection. So a balanced discussion means that you talk about the efficacy, the side effects, the procedure, and the cost, and the insurance coverage. This is all part of that shared decision-making process, and you need to do it for each of the medicines. So there's a lot of detail that has to be discussed at each of the branch points in your treatment decision that you're going through. So all of these different aspects need to come out. It sounds more complicated than it really is. It doesn't take that much time to go through each of these concepts. But, I like to split the visit in half, right? The first half of the visit is the history taking, the examination, the diagnosis. The second half is all the education and the discussion about the management.
I appreciate that you brought up payers and the barriers. I'm going to share a quick story that my neurologist is helping me as a patient. I get Botox and I take another medication when I have attacks that works really well. There's a couple of weeks when the Botox wears off that I end up increasing frequency of migraine attacks. That's fairly common, I'm told. We found that if I go on a different everyday medication, that really is good for that bridging period, especially if I'm undergoing other stressors like traveling and time zone changes. And I've been able to try it and it works really, really well. And I essentially have migraine freedom. Our insurance company doesn't want to pay for it. And recently, this has been going on for about 2 months. I said to my doctor, I said, you know what? I'm fine enough. Like, you're wasting your time with the prior authorizations and the energy that I'm expending to try to get it for like 2 or 3 weeks. Is it like really that important? And he was like, yes. And I've gotten other patients on this in this way. If it works, it's silly that you're not going to push for it. And he is continuing to fight with them, peer-to-peer reviews and all that fun stuff. So I think it's great when you have a provider that pushes you too, because I'm a very educated patient and I was backing away because it was like way too much effort. And I feel bad for our providers that have to go through all of these hurdles to like help us feel better. So I'm glad you brought up that we're sometimes limited or have to be creative based on payers.
I think there's one important point for you to remember as you go through this process is that every time you're breaking through and having a migraine, like at that end of the treatment cycle, you actually take a step back in your long-term prognosis. Every time the brain is exposed to migraine, it sensitizes the pathways, so it makes it easier for the next attack to happen. So when we talk about getting control, we need to prevent the amount of time the brain is spending in migraine in order to decrease the sensitization. You know, in the US, we're very lucky that a lot of the payers allow us to use these medicines when the headaches start to come under control. What happens in Europe is they have stopping rules where when the patients drop below a certain level of headache, they stop the treatment. Then the headaches come rushing back. They resensitize the brain. And now these people are back at square one. They're starting over. And so it's like a yo-yo effect. What we're trying to achieve is a gradually progressive improvement without any step back. And that's a very important concept for people to remember.
Yeah, what happens in Europe with that horrifies me, something that we follow. And the logic is scary that you are cured, essentially, where the payers say that you are because you're being managed. And then we see, as you just said, that the attacks come back for the most part. And obviously, there are outliers that might not have attacks after that. But for the most part, they come back. And you have to start that process again. And I'm hopeful that the United States doesn't look overseas and say, oh, we could save, 3 or 4 months of treatment compounded by X number of patients in the country. And that would be really big to our bottom line. So let's torture these folks and take them off of their medication. So we actively monitor that. And it's quite frightening. And yeah, really appreciate you bringing up the chronification issue. It's something that I don't think about enough personally, but it's important to know that you need to be aggressive and proactive with your treatment because, as you stated, the more migraine attacks that you get, the more likelihood that you will get chronic migraine or intractable migraine. And that's something that we want to stop, and we can. So appreciate you raising that point. One other quick question on this topic. You talked about drivers of headache disorders. Is it fair to say that those are comorbidities? And what are some of the common ones that you look at first when you're looking at that?
Well, they're comorbidities and also coexisting diseases. There can be an overlap. So sleep apnea was the classic example. So sleep apnea can produce a wake-up headache in the morning. Usually it lasts less than 4 hours, and it's a headache on both sides of the head, mild to moderate, not with a lot of nausea or lighter noise sensitivity, but then it could evolve into migraine. The patients with sleep apnea have daytime fatigue, so they may start to use a lot of caffeine to stimulate them. But then the caffeine can start to act as a driver of headache. So there you see the complication of this, how one thing leads to another, and it all spirals out of control. So it's very important to look at caffeine content as part of your history taking, as well as looking at all of these comorbid conditions that can drive the underlying headache problem. Things like underactive thyroid, anemia, these can definitely aggravate headache. And there are also studies that have shown that there can be an overlap between chronic migraine and conditions that cause raised intracranial pressure. So, for example, COVID can cause a lot of blood clots in the body, including in the brain, and it can clot up one of the sinuses in the brain that drains fluid. And so you could get raised intracranial pressure after having had COVID. And that might aggravate your headaches in of itself, not because it's making migraine worse, but because now there's another cause for the headache. COVID can, just without causing a blood clot, give you an increase in headache. That's well known. COVID in of itself causes headache. It can worsen underlying migraine, but then it can cause these secondary problems. So you need to consider all of these aspects when you're addressing the headache disorder. So looking at all those secondary drivers is very important, and then including medications and caffeine as well.
So let's talk about caffeine. It's one of my favorite things in the world. What's the deal with caffeine and migraine? Is it similar to medication overuse headache? Is it a trigger? How do you talk to your patients about caffeine?
I think there's a lot of misinformation about caffeine. A lot of people believe that caffeine is beneficial for headache. That's true. You find it in a lot of compounds like Excedrin and Furanol, Furosat. These medicines include caffeine as part of a treatment. And if you have occasional migraine, let's say you had 1 or 2 attacks a month, you might find that having a Diet Coke with an anti-inflammatory is enough to break that headache. And that pattern of use is just fine. What becomes problematic is when you start to rely on caffeine on a daily basis to prevent headache. So one of the clues there is that you wake up with headache in the morning and it doesn't go away till you've had your first cup of coffee. You know then that you're in a caffeine withdrawal headache when you wake up. By having that extra coffee, you're not really solving the problem. You're just delaying it to the next day when you're going to wake up again with a new caffeine withdrawal headache. So in that situation, less caffeine is the solution, not more caffeine. But caffeine withdrawal, so if you're having a lot of caffeine in your diet, caffeine withdrawal headaches can be very severe, typically last about a week and then abate. So it's a matter of getting through that week of withdrawal. The upper limit of caffeine use that is good for a patient to know about is 200 milligrams a day. So what I encourage patients to do is to look at their brand of coffee and to go online and see what the caffeine content is so they can calculate out the 200 milligrams a day. It's useful, most of the coffee shops, these gourmet type coffee shops, will have a website where you can check the caffeine content of the individual beverages. One of the important points to remember is that having a regular cup of coffee has a lot more caffeine in it than an espresso shot. Espresso shots typically are 35 milligrams per shot. So if you're allowed 200 milligrams of caffeine a day, you could have quite a few espresso shots. So if you were drinking lattes, you might be fine. But a regular cup of coffee could be anywhere from 200 to 400 milligrams a day, depending on the size. And so that would have been much worse than the espressos. So just remember the 200 milligram rule. Don't get to exactly 200, target being under 200. If you do decide to withdraw, let's say you were drinking, 8 cups of coffee a day and you were well in excess of 200 milligrams, what I typically do for that week of withdrawal is I'll use a long-acting triptan, one of the longer-acting triptans, like narrow triptan is a good one. And I'll use that every day for that week as a sort of mini prophylaxis. And that often prevents the withdrawal headache. And then you can always do nerve blocks or a short course of steroids if it gets bad. So there are methods to help you withdraw. Because overall, for your overall health, drinking a lot of caffeine is not good. It can take calcium out of the bones. It can increase your heart rate, trigger other things that are not necessarily good for you. And having said all of that, in someone who was drinking 8 cups of coffee a day, you would also want to make sure they don't have sleep apnea, because maybe there's another reason. So it's looking at this bigger picture.
And would you titrate or like slowly reduce the caffeine with your patients, or do you have them go cold turkey?
It really depends on the extent of it and also the individual's willingness. A lot of people, and this seems to be true for you, are very attached to their caffeine. One patient gave me a mug with a graphic on it of a woman in a rocking chair with a shotgun on her lap and said, "Don't come between me and my coffee." And I think that's how you feel too. But, this is part of the shared decision-making process, is understanding all the aspects of what's happening and then working out a plan that would work for you. You might want to taper off more slowly, and we could do 2 weeks of narrow triptan to give you a slower taper. If you're going to taper over months, you might be able to do it. You just have to have the discipline. You might not need as much treatment. You might use narrow triptan on a particularly bad day then, or a nerve block, things like that. There are ways to do it that will fit each person's individual need.
And switch to espresso. I'm about that life. I love an espresso. One other thing to note too, when we're talking about caffeine, if you are going to the gym and you're involved in gym culture, a lot of the energy drinks that people will have for pre-workout, ton of caffeine on the lower end, 200 milligrams. So it's really important to look at your caffeine use across the board. Energy drinks, you talked about over-the-counter medications that might have caffeine in it, potentially chocolate. There's all these other areas that you can get caffeine from. And we talk about it with Tylenol and over-the-counter medications to look to see where you're getting all the different amount of acetaminophen. But with caffeine, it's a similar concept. And I didn't realize for a little bit, I was like, oh, this energy drink that I'm drinking, in addition to the coffee, that's a lot of caffeine and I have to stop that. So it was a lesson that I learned somewhat the hard way, but make sure you understand what you're consuming. So this has been such a great discussion. I've gotten a lot out of it. I know our audience will. Is there anything that I didn't ask you that you wanted to highlight or underscore or share?
Well, I think we've discussed a lot of the newer concepts. Just understanding the process that the provider has to go through to get you this higher level of control is useful for patients to understand. The prior authorization process, as you point out, is very difficult for the office. But, the ultimate goal is to try and get to crystal clear days. And the way that I define a crystal clear day is no pain from the time you wake up until you go to bed above the level of the shoulders. A lot of patients with headache disorders, when they come in for the visit, they tell you about their worst days. They don't necessarily report all the days. And this is a flip on the way of thinking about it. If you think about your headache-free days, how many days are really headache-free? And explain that to the provider when you're visiting. That's actually a much better guide of where you are starting from than to talk about your bad days. I often get patients saying, I just want to talk about my migraine days. They're actually all migraine. The migraine is a spectrum. Some days you have a mild headache, that it's still a mild migraine. And then other days you have the full-blown attack. It's not like they're the different buckets. We have to look at the whole picture.
My life changed when I applied that concept. And I got on different medication, and I didn't realize that having a headache every day, and like you described, very low grade, I would describe it as like static noise in the background. Like I knew it was there, but it didn't really interrupt my life, but it was there. And then knowing that, and then knowing what it's like to not have a headache and talking to people that have never even had a headache blows my mind, because I was like, I just thought everyone had headaches and it was just what happened. So reframing it that way and sharing, oh, I pretty much have a headache every day, enabled me to get on different treatments based on insurance protocols and step therapy and criteria for prescribing. And that has improved my quality of life tremendously. So it's something I advocate, and GHLF advocates for very, very forcefully, is to talk to your provider about your headache days and not just the really bad ones like you described. So thank you for raising that point.
And the final area that I'll just mention very briefly is that one of the areas that we are starting to look at with migraine is the period between the attacks. So this is called the interictal period. And what we're seeing is that patients with migraine have symptoms in the interictal period that are in of themselves disabling. these are not necessarily symptoms tied to headache. It's not that you're just worrying about the next headache that's coming. It could be fatigue or slow thinking or motion sickness or vertigo or neck discomfort, nausea. So there are lots of other symptoms that are brain symptoms that continue in the interictal period. And I think this is an area that you're going to start to see a lot more research, where the medications that we use to control the condition also need to control these other symptoms, which we have ignored to a large extent.
Very, very important. And I've looked at some of that research. I've tried to understand as much of it as I can as a non-researcher, and it looks very, very interesting and exciting. And ultimately, it's about making people feel the best that they can feel. And we're looking at this disease in a different way, that it's not only the headache, the migraine attack, that it's when the light hurts your eyes, when you feel dizzy, all these other things that go along with it that we didn't discuss or we pushed aside or we didn't think medication could solve, or lifestyle changes. I know that that's important as well. So yeah, that interval period is something that is of great interest. And I know that there's really smart and good research coming out around that. And I'm sure you're involved in some of it.
Yes.
Thank you so much for being on Talking Head Pain. This was a super informative discussion. I'm going to think about coffee a little bit more. I'm glad that espresso is good. And my Italian culture feels validated. So appreciate your energy and time. I know you're super busy, and I know that our audience will get a lot out of this meaningful discussion.
Well, thank you. Thank you very much for excellent questions and for guiding this discussion.
Thank you for listening to this episode of Talking Head Pain, the podcast that confronts head pain head on. If you have any questions, thoughts, or suggestions for us, you can send us an email at podcast@ghlf.org. If you enjoyed this episode, please give it an honest 5-star rating, write a positive review, and spread the word by sharing it with your friends and family. It'll help more people like you find us. I'm Joe Coe, and I will see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.